Hello, everybody. Today we're gonna talk about a very important aspect of infectious diseases, which is how to prevent infectious diseases. Many times we are concentrating on treating infectious diseases, but prevention of these infections is as important, if not more important, when it comes to public health in the community as well as in the hospitals. So we will start with a few definitions. Uh, Starting with the definition of infection. Infection is the ability of an organism to gain access to a host and multiply. So the organism has to have access to the host. Most of the time, it has to penetrate the defenses and it has to multiply in order to establish an infection. And the organism can gain access to a host through inhalation, via the respiratory tract, through ingestion via the gastrointestinal tract, by invading skin, whether it is intact skin. Some organisms are able to invade intact skin, and others they need a wound in order to invade. Sometimes insect bites, they serve as a way for the organism to gain access, and that's why some people, after being bitten by an insect, can develop infection at the site of the bite. And the fourth way of getting access to the host is through parenteral transmission, meaning through bodily fluids. This is through sexual exposure, through exposure to blood and body fluids, such as with shared needles among people who do IV drugs, through the placenta from the mother to the fetus, and this is called parenteral transmission. So this is what an infection is. An infectious disease is what the patient is experiencing. It is the collection of symptoms and signs that the patient is experiencing and the illness that results from the host organism interaction. A communicable disease or a contagious disease or a transmissible disease is the entity that can be transmitted, whether directly or indirectly, from one host to another. Most infections are transmissible from one host to another, but not all infections are transmissible from one person to the other directly. So, for example, measles can be transmitted from one person to the other. COVID-19 can be transmitted from one person to the other. Influenza. But for example, brucella, it cannot be transmitted from one person to the other. It has to be transmitted from the original source, which is the infected meat or infected dairy product. Malaria cannot be transmitted from one person to the other. So when we say a contagious disease, contagion means usually that it is transmitted from one host, one human being, to another human being directly. So all infections are transmissible by definition, but not all of them are contagious from one person to the other. What is infection prevention? Infection prevention encompasses all the practices that are used to prevent the spread of microbes, whether we use them in the hospital or in the community. In the hospital, the infection control practices, they help to protect the patients, but also the visitors and us as healthcare workers. So we want to have the hospital as a safe environment for all people there, the patients, the visitors, and the healthcare workers. And indeed, a gram of prevention is worth a ton of cure. So that's why I started by saying that prevention of infection is as important, if not more important, than treating such infections. Over the years and over the centuries, the incidence and the fatality of infections have decreased. In the Middle Ages, people used to die from cholera, from the plague, from other diarrheal illnesses. Why? Because the public health measures were very bad. Now that we have, in most cases or in developed countries, improvement in public health measures, sanitation, better nutrition, greater prosperity, that makes the incidence and fatality of infections much less. Now, that will not apply in areas of conflict, for example, such as Yemen, or in the very poor areas of Africa, where still they don't have access to good nutrition and good sanitation. When we say sanitation, we really mean the most important is water. You cannot have a public health system without having access to clean water. That's even more important than clean food, because you cannot cook food with bad water. So clean water is at the basis of public health measures to ensure a low incidence and fatality of infectious diseases. Not only were there improvements in public health measures, but there were also the introductions of several immunizations, whether against polio, against measles, against smallpox, against influenza nowadays, and these have decreased the incidence and fatality of childhood infections and many infections across the board. The third component of contributing to the incidence of infections is the presence of antimicrobial therapy. Before the 1940s, there were no antibiotics. It was only in the 1940s that penicillin was introduced, and it was used first in soldiers that were fighting in the Second World War, and afterwards there were many types and many families of antimicrobial agents until now, where they still are discovering and basically manufacturing new antimicrobials. So the advent of antimicrobial therapy had a very, very important impact on infectious diseases and their epidemiology. Now, what are the levels of prevention? There are 4 levels of prevention that we talk about. The individual level, which is the domain of the clinician. So you, in the future, in your clinics, you will be doing individual level prevention. There is the second level, which is institutional. This is basically when we, as infection control practitioners and healthcare facility, we have measures to control the infections in the workplace, in the hospital. This is institutional. There's also a community level prevention, which is the domain of public health agencies. And you have national and international levels, which is the domain of WHO, the Ministry of Public Health, UNICEF, etc. So when we talk about individual prevention, as we said, this is predominantly the domain of the clinician. And it includes a variety of activities. And we target individuals in the community setting, but also in the hospital setting. So when I have someone in the clinic and I tell them, please wear a mask when you have a cold, this is individual level prevention in the community setting. And in the hospital, when I have a patient who is going for laparoscopic cholecystectomy to remove an inflamed gallbladder, and I give them an antibiotic before surgery to prevent wound infection, that's what we call individual level prevention in the hospital setting. So this is when you are targeting an individual person, okay? And when you're targeting an individual person, that's a one-to-one relationship usually with the physician. What about institutional prevention? As we said, this is predominantly the domain of the infection control practitioner, or it could be the school, the college, a health official. It depends on the setting. What institutions are we talking about? We are talking about healthcare facilities such as hospitals, clinics, dispensaries, but also nursing homes and long-term care facilities, prisons, correctional facilities, military facilities. These are places where people are living in close quarters and where there is a risk of transmission of infection from one person to the other, but also colleges such as AUB campus, for example, and in the dorms, to have levels of prevention to make sure that everybody is safe. So an example of an institutional level prevention is strategies and programs to prevent bloodborne pathogens or tuberculosis to healthcare workers in hospitals. So when I, as an infection control program, decide to have a yearly PPD test to healthcare workers that are working in the hospital, that's an institutional level prevention. When I decide to vaccinate healthcare workers against hepatitis B, That's also an institutional level prevention. I'm using it at the institutional level to prevent the spread of infection there. The third level of prevention is community-based prevention, and this is the domain of public health agencies and local municipalities. And it targets a local community where they're trying to prevent or control the spread of an infection. So for example, if I have a village in Akkar and the municipality in Akkar is investigating an outbreak of Salmonella diarrhea, that's considered a community-based prevention or activity. And the fourth level is the national and international level of prevention. And this is, as we said, the domain of international and national health agencies. And this occurs when the problem has national and international ramifications. The examples are the H1N1 pandemic, the COVID-19 pandemic, the HIV pandemic, the SARS pandemic. All of these, they require agencies at the international level to release guidelines, to give guidance to the clinicians, to the communities, to the local workers in order to prevent the spread of such infections. So when you have potentially large ramifications, this is national or international level prevention. Now, certainly overlap does occur. Some programs are specific to one level, but overlap does occur among all levels. So for example, when I have an immunization program, I am targeting the individual, I am targeting the community, but with the COVID-19 vaccine, for example, I'm targeting the entire human population. So immunization programs, they occur at all levels. And certainly, as we said, overlap does exist. Just like there are different levels of prevention, there are also different forms of prevention that we'd like to talk about. Primary prevention, secondary prevention, tertiary prevention, and quaternary prevention. And you can think of it as a 2x2 table with the disease on one side and the illness on one side. The disease meaning the doctor's side, what the doctor is seeing as far as abnormalities in the labs, on physical examination, etc. Whereas on the patient side, it's the symptoms and what the patient is feeling. So if we have an illness that is absent and the disease that is absent, meaning the patient is feeling nothing and there is no disease, we call it primary prevention. Secondary prevention, and we'll give examples of that. Secondary prevention is when there is no illness, meaning the patient is not feeling anything, but the disease is present, meaning there is asymptomatic disease. With tertiary prevention, both the illness is present and the disease is present. Then we will talk about what are we trying to prevent. If the illness is already there and the disease is already there, what am I trying to prevent? This is what we'll see in the slides to come. With quaternary prevention, you have the illness is present, so the patient is feeling something, they have an illness, but there is no disease, meaning that the patient has symptoms, but the disease in question is not there, and we have to try to figure out why the patient is feeling ill if they have no disease. So with primary prevention, when the disease is absent and the illness is absent, the aim is to prevent the disease from occurring. So there is nothing there. There is no infection, there is no illness. So what you're trying to do is prevent something from happening that causes an infection or that causes an illness. And there are two types of prevention in this case. We can have either immunoprophylaxis, and prophylaxis in general is the medical term for prevention. So we have immunoprophylaxis or chemoprophylaxis. Immunoprophylaxis meaning that you are using products of the immune system, meaning antibodies. Within immunoprophylaxis, we have active immunization or passive immunization. Active immunization is the regular vaccine preventable illnesses, such as the routine childhood vaccinations, travel-related vaccinations, such as the typhoid fever vaccine, vaccination in at-risk populations, such as hepatitis B vaccine in healthcare workers, occupational exposure, such as the rabies vaccine in a person that works at a zoo, for example. This is called active immunization within the immunoprophylaxis. So you are giving active antibodies to prevent a disease from occurring. Active vaccine in order to prevent the disease from occurring. With passive immunization, you are giving a preformed antibody. This is why it's called passive immunization. Active immunization is when you rely on the immune system to produce the antibodies. With passive immunization, you are giving the patient preformed antibodies. Preformed immunoglobulins, such as when someone comes to the emergency room and they have stepped on a nail, we give them the passive immunization for tetanus, we give them the preformed immunoglobulins. If someone has been exposed to hepatitis B and is not immunized, then we give them the HBIG, the hepatitis B immunoglobulins, and so on and so forth. The rabies immunoglobulins in patients who have been bitten by dogs or by wild animals. All of these are part of immunoprophylaxis and passive immunization. The other type is chemoprophylaxis. And when we say chemoprophylaxis, it means it's drug. Immunoprophylaxis, it's immune system. Chemoprophylaxis is drug. And with chemoprophylaxis, it can include drugs that are given before exposure or after exposure. So before exposure, for example, malaria. Someone comes to my clinic saying, I'm going to travel to Nigeria for 3 months for a small business trip, and what should I do? We don't have a vaccine against malaria. We have chemoprophylaxis against malaria. We have a drug that can prevent malaria from happening. So we give them, prescribe for them, pre-exposure prophylaxis for malaria because they have not been exposed before. Same thing for surgery. The example that we gave about giving antibiotic before surgery in order to prevent surgical site infection, that's pre-exposure prophylaxis. Whereas with post-exposure prophylaxis, the person has been exposed to the organism but has not developed the infection yet. You give them a drug to prevent the development of the disease. The example is Neisseria meningitidis. So Neisseria meningitis, in a dorm, for example, in a college dorm, one student comes down with the illness. All of the people in the floor, or his roommate at least, should receive post-exposure prophylaxis for Neisseria meningitis. Because if they have been exposed, you will prevent the development of the disease by giving the antibiotic post-exposure. So this is what we mean by immunoprophylaxis, active immunization, passive immunization, and chemoprophylaxis pre or post-exposure. And that's all primary prevention. No disease, no illness. With secondary prevention, we're talking about asymptomatic infection. So there is disease, but there is no illness, meaning the patient is feeling nothing. So what do? We give the prevention in order to prevent the development of symptoms. For example, someone has latent tuberculosis, and you're giving treatment in order to kill the tuberculosis so that the person does not develop active pulmonary tuberculosis. That's secondary prevention. The disease is there, the infection is there, but the patient is asymptomatic, has no illness. So the treatment is therefore secondary prevention. When I have a patient coming to me with Neisseria gonorrhea or chlamydia urethritis, and I ask them, who are your sexual partners? And they are asymptomatic, then what you're trying to do is, they're probably infected, but what you're trying to do is give them treatment so that they don't develop a symptomatic infection. Same thing for HIV. If I have a patient who comes to me on routine screening, was found to be HIV positive, he has the infection, but he doesn't have the illness because he's not feeling anything. So what we do is we give them treatment for HIV infection, because it is an asymptomatic infection, and that's secondary prevention. There is disease, but there is no illness. With tertiary prevention, both the disease and the illness are present. So the patient is ill and they have definitely evidence of disease. So what are we trying to prevent? What we're trying to do is to prevent the long-term disabilities of an existing infection in order to lessen the suffering. For example, someone has AIDS, full-fledged AIDS, and they have a very low CD4 count. What you do is you give them prevention to prophylaxis to prevent against opportunistic infection. The illness is there, the disease is there, but you give them antibiotics to prevent superimposed opportunistic infections in such patients. Another example is measures to improve the quality of life of patients with chronic hepatitis. So you have someone with chronic hepatitis, the illness is there, the disease is there, you're trying to improve their quality of life, and that's tertiary prevention. With quaternary prevention, we said that the illness is there, the patient is feeling ill, but the disease is not there. So they don't have an infection, but they are still feeling ill. An example is someone who is taking antibiotics for the treatment of a simple common cold. The illness is there, but the disease in question that we are trying to treat with antibiotics is not there. There is no bacterial sinusitis, there is no bacterial pneumonia, there is no bacterial pharyngitis. So giving antibiotics for the treatment of viral infection is an example that has to be targeted by quaternary prevention. So what you're trying to do is to prevent unnecessary medication or unnecessary medicine or over medication. And that's what quaternary prevention is. Illness is there, but the disease in question that you're trying to treat is not there. Therefore, you should stop the treatment, and that's quaternary prevention. And now in the remaining time, I will talk about hospital-acquired infection, because the prevention of these types of infections is very important for us as healthcare workers, and it is one of our utmost responsibilities. These are infections that are occurring in patients after admission to the hospital that were neither present nor incubating at the time of admission. So for example, someone gets admitted at 8 a.m. this morning. At 12 noon, they start having fever and they have pneumonia. That's not a hospital-acquired infection. That's probably an infection that was brewing or incubating upon admission, but it manifested after admission. So the usual time period that we allow is 48 hours. Any infection that manifests itself 48 hours or more after admission is considered a hospital-acquired infection. What are the implications of why are they important? They are important because they increase morbidity, meaning they increase the dependence of the patient on medications. They have worse outcomes and worse quality of life. They definitely increase mortality. So some people, they have fatal hospital-acquired infections. They increase hospital stay. Someone comes in for cardiac catheterization. They should stay 2 days in the hospital. During the hospital stay, they develop hospital-acquired pneumonia. Now they have to stay for 7 days. That's an increased hospital stay and increased cost. And at the same time, because in the hospital you have a circulation of multi-drug resistant pathogens, these are more likely to be encountered with hospital-acquired infections. So when you have someone who develops a hospital-acquired infection, then they are likely to spread this multi-drug resistant pathogen. Of course, it results in bad reputation of a hospital. We went into the American University of Beirut or Hospital X or Hospital Y وعملنا infection and that's bad. And this is a very small country, people talk, and you have a bad reputation of a hospital if people are going in and acquiring infections inside the hospital, which can also result in legal action against physicians and or institutions. So we have to be very careful and do our role in preventing hospital-acquired infections. Which leads us to the chain of infection. In order for infection to happen in the hospital or outside, it has to have a chain of infection. And once you break the chain, especially if you break it at multiple points, you have prevention of infection. And the chain of infection is made up of several links that start with the infectious agent, the reservoir, the portal of exit, transmission, portal of entry, and host susceptibility. And we'll talk about each link separately. So the infectious agent, where is it? It could be from a resident flora, meaning it normally resides on the skin in stable numbers. For example, all of us have coagulase negative staph on the skin. This is a normal occurrence. It is not considered an infectious pathogen. It is considered part of the normal or resident flora, and it's not causing any problems. These are resident flora, but there's also transient flora. These are attaching loosely to the skin by contact with another person or object. For example, I go in a patient's room and they have methicillin-resistant Staph aureus on their skin. I fail to perform hand hygiene correctly. I go in, I go out, and then I go into the next patient's room and I touch them, again not performing hand hygiene. And now this transient flora, which is MRSA, has been transmitted from one patient to another. This transient flora is easily removed by hand washing, and that's why we have to pay a lot of attention to hand washing, as we will see later on. So this is the first link in the chain of infection, the infectious agent itself. And the infectious agent is present usually in a reservoir. This is where the pathogen survives, but may or may not multiply. This is the basic source of the pathogen. And there are two types of reservoirs. There are human reservoirs and environmental reservoirs. When you have a human reservoir, it will be colonized or infected patients. So for example, if I have a patient who has a wound and that is draining and it's an infected wound, then this wound drainage is considered a reservoir because this is where the organism really is teeming. Urine bags, they can act as potential reservoir. Stools, if someone has infectious diarrhea. Respiratory secretions, someone has influenza and every time they cough, they produce respiratory droplets that can carry the influenza, and this is a reservoir. So the respiratory secretions and the respiratory tract is considered a reservoir. We as healthcare workers and visitors can also act as reservoirs. So for example, if I have a medical student or a resident or a physician with having Staph aureus in the nares and it's living there, the person who is carrying the Staph aureus feels nothing. They are totally asymptomatic, but they are acting as reservoirs to spread the infection to others, especially if they do not perform hand hygiene. Some people carry group A strep in their pharynx without having a clinical illness. They are asymptomatic, and that's why they also serve as human reservoirs. The reservoir can also be the environment, an inanimate object, such as the ventilating system. Water, infected water can act as a reservoir. Medical devices, such as the stethoscope, if you have used the stethoscope on a patient who is infected and then used it on another without disinfecting the stethoscope in between patients, then the stethoscope will act as a reservoir or as a vehicle of transmission. IV solutions, so we give patients solutions in the IV bag, and if they are infected, they usually are infected due to a manufacturing problem, and they can transmit infections in this case. The third link in the chain of infection is the portal of exit. So the infectious agent, number 1, is present in the reservoir, number 2. Now it has to exit the reservoir. In order for an organism to be transmitted to someone else, it has to exit the reservoir. And it exits the reservoir through portals of exit. It could be through the respiratory tract by sneezing or coughing. It could be through the gastrointestinal tract with the vomitus or stools. It could be via the skin. The portal of exit could be the hands of the healthcare workers that are the reservoirs, but when they touch someone else, this is also the portal of exit. Ventilation equipment, urinary catheters where the urine flows out and is infected. Wounds and wound dressings, bed rails. The patient's bed rails, they can act as reservoirs and portals of exit. Phones and computers, keyboards. This is how the organism exits the reservoir in order to be transmitted to someone else. The fourth link in the chain is transmission. The organism is in the reservoir, exits the reservoir through the portal of exit, and then there is a mode of transmission that we have to talk about. The mode of transmission can be several. It can be through large droplets. These large droplets, such as with influenza virus or with common cold, they are large, so they are heavy, and they travel, because they are heavy, they travel short distances in the environment, in the air, and then they drop to the floor. And it's usually 3 feet or 1 meter. Okay? So these are large droplets. The moment they exit, so for example, someone sneezes, the respiratory secretions are the reservoir. The respiratory tract is the portal of exit. And the droplets, the large droplets, are the mode of transmission. If this is influenza virus, then it will be packaged in large droplets and they will drop to the floor. So anybody that is beyond 3 feet or 1 meter is safe. But with airborne transmission, such as with Mycobacterium tuberculosis, it is still droplets, but the droplets are fine and small, and because they are small, they are carried by the wind and the air, and they can travel large distances. So for example, if you are on the plane and the person next to you has influenza, you're likely gonna catch it unless both of you are wearing masks, because you are sitting within 1 meter, very close contact with the person who is infected. But if you are someone with influenza at the front of the plane and you are sitting at the back of the plane, then the risk is minimal to non-existent. But if someone on the plane has Mycobacterium tuberculosis, then the entire plane is at risk. Why? Because the organism is traveling in small droplets that are carried on airborne, and they can travel long distances. The third mode of transmission is contact. It's through direct or indirect contact. Direct contact is skin to skin. I touch a patient, I don't wash my hand, I touch another patient. That's direct contact, which can transmit Staph aureus, C. difficile, etc. It could be also indirect contact. I touch the patient, I go out, I don't perform hand hygiene, I touch the bed rail of the patient in the next room. Then the patient touches his bed rail, and there is indirect transmission by contact. Okay? Or the doorknob, or the phone in the room. I answer my pager. Okay? I now contaminate the receiver of the phone, and then the patient answers the phone and gets infected through indirect contact. So contact can be direct or indirect. Contact direct meaning skin to skin. The fourth mode of transmission is parenteral transmission, and we've discussed it before, such as hepatitis B and C virus, HIV. These are transmitted through blood and body fluids. Tattoos, shared needles, blood transfusions from mother to fetus, all of these are parenteral transmission. And then the fifth and last mode of transmission is vector-borne, which is the example of which is malaria or Lyme disease. So, for example, malaria, as we said, is not contagious from one person to another. You need the vector, which is the Anopheles mosquito, to transmit the organism from one person to the other. But direct contact from one person to the other, either by droplets or by skin-to-skin contact, etc., it does not transmit malaria. Okay? So these are the 5 modes of transmission in the chain of infection. So where are we now with the chain of infection? There is the infectious agent, again, in the reservoir, exiting through the portal of exit, using a mode of transmission, And in order to infect another, it has to have a portal of entry into the another person. And the portal of entry can be the nose. So the droplets that have been ejected from one person can enter through the nose of someone else. It could be the mouth. It could be the mucosa of the eyes, for example. So if someone sneezes in your eyes, and you're even if you are wearing a mask but you are not wearing a face shield and your eyes are exposed, the droplets can go in and they can infect you through the mucosa of the eyes. So the nose, the mouth, and the mucosa, they are all susceptible to droplets. And then you have open wounds, and these are susceptible to contact type of transmission. So if I touch an infected person and then someone has a wound and I touch it again, then it is considered a transmission, and it's a portal of entry. Intact skin is usually not considered a portal of entry. Usually it is a portal of exit. Why? Because the organism can live on the skin on the outside. But most organisms, will require a breach in the skin in order to infect. So a wound, it may be a small wound, but the intact skin usually is not considered a portal of entry. It's considered a portal of exit, but not a portal of entry. Open wounds are considered portals of exit and entry at the same time. It could be portals of entry, could be also invasive procedures. Invasive procedures which also breach the skin. So if I cut someone to perform a surgical procedure, a hernia repair, I am cutting the skin, and if I'm not careful, I am allowing the organism to enter into a sterile space and cause infection. Okay, same thing if I have an IV catheter, in order for the person to receive IV fluids. So this is the portal of entry. And the last chain, a link in the chain of infection, is host susceptibility. When you have a portal of entry, if the person is immune or not susceptible, the chain stops there, and the infection does not disseminate. So for example, if all the chain of infection is intact, but I am immune to hepatitis B, even if I receive infected blood, the chain of infection stops there. So host susceptibility is important. Immunocompromised patients are susceptible because they have a problem with their immunity. Critically ill patients, they are susceptible because, again, the immune system is compromised because of the critical illness. Non-immunized patients, had I not been immunized against hepatitis B, if I receive a contaminated transfusion, then I would have been infected. So host susceptibility is important. Extremes of age, the infants and the elderly are more susceptible because they have weaker systems in general. And healthcare workers are susceptible because they are more likely to be exposed. I am more likely to have a needle prick injury compared to someone who works at a bank, for example. So by virtue of our profession, we are more susceptible because we are more exposed. So in order to reduce susceptibility to infection, it's important to provide adequate nutrition and rest, promote body defenses against infection, such as providing adequate nutrition and providing immunization. So someone who is not immunized against measles, they will be susceptible. But someone who is immunized against measles, even if they are exposed to measles, they will not get infected. So in the end, we need to break the chain of infection through infection control practices. And in order for the chain to be really broken effectively, we have to try to break it at multiple points. So we have to control the reservoir and make sure that if we have a contaminated reservoir, to clean it, to get rid of it. We have to control portals of exits. So if someone has sneezing, they have to cover their mouth and their nose. That's how you control the exit. We have to control the portal of entry. Again, wearing a mask in order not to have droplets traveling into your respiratory system. We have to deal with the host susceptibility by providing immunization. So when you break the chain of infection at multiple links, then you have good infection control practices. And in the last portion of the talk or the lecture, I'm going to talk about hand hygiene. And we are going to hammer hand hygiene with you from now until you enter into Med 3 and throughout Med 3 and Med 4, because this is a very important part and responsibility of ours. So why all the fuss about hand hygiene? The most common mode of transmission of pathogens is via the hands. It's the easiest mode of transmission of pathogens, all types of pathogens, whether they are respiratory. If I touch my nose and then I touch someone and I shake the hand of someone and then that other person touches their nose again, I've transmitted the infection. So it is the most common mode of transmission of pathogen. So it leads to healthcare associated infections, because if we as healthcare workers don't perform hand hygiene, we can contribute to the development of healthcare associated infections and the spread of antimicrobial resistance. Both are important. Most healthcare associated infections are due to antimicrobial resistant pathogens, and they can lead, as we said, to increased morbidity and mortality. And it would be unethical for us not to address this and for us to be, instead of treating the patient, to be a source of infection to the patient. So what are the top 10 causes of hospital-acquired infections? They are your 10 fingers and the hands. These are the top 10 causes of hospital-acquired infections. Once we control hand hygiene, the number and the incidence of hospital-acquired infections will drop significantly. So let's apply the chain of infection, of the chain of transmission, to the issue of hand hygiene. Bacteria are transferred to the hands of healthcare workers by contact with the patient. The bacteria, these are the transient flora that we talked about. They will survive for several minutes on the hands of personnel. And then there is inadequate or lack of hand hygiene by healthcare workers. They go into a second room, they have direct contact with another patient or with an inanimate object in the vicinity of the patient. So I put my contaminated hands on the bed rails of the patient, and then the patient touches the bed rails again, and I have resulted in an indirect transmission via indirect contact. And this is very, very, very important. And here is a picture of an agar plate where someone has pressed their unwashed hand on the agar plate, and look at how many colonies of bacteria there are. If we were to see the bacteria on our hands, we would be washing our hands many more times than what we are actually doing right now. That applies for COVID, that applies for influenza, that applies for Staph aureus, for C. diff, for a lot of pathogen. Hand hygiene remains the cornerstone. So when do I need to perform hand hygiene? Before and after contact with patients and or their surroundings. So if I come in contact with the patient and or anything in their surroundings, before and after, I have to perform hand hygiene. After contact with any body fluid. So if I have contamination of my hands with blood, mucus, wound drainage, stool, urine, unexpectedly, because if I expected, I should be wearing gloves, but unexpectedly, right, the patient has they sneeze, and my hand is near, and I suspect that there is some mucus on my hands, or if, for example, the urine bag breaks and I get contaminated with urine, etc., I need to perform hand hygiene. We should also perform hand hygiene after contact with our body fluid. So basically, when you are going to the bathroom, or when you are touching your nose, when you are using the tissue to wipe your nose, you have to perform hand hygiene afterwards. We also have to perform hand hygiene before and after donning gloves. So a lot of students tell me, Doctora, why should I perform hand hygiene? I'm wearing gloves. Wearing gloves does not obviate the need for hand hygiene, because you will contaminate the gloves with your contaminated hands and you will have transmission. So you have to perform hand hygiene before and after putting on the gloves. If the hands are visibly dirty, obviously we have to perform hand hygiene before eating and drinking in order to protect ourselves as well, and after using the restrooms, obviously. How to perform hand hygiene? There are two types of hand hygiene procedures that are available to us as healthcare workers. We have the soap and water, and this is, we have to basically have foam on our hands and scrubbing for 30 seconds. It's not just 2 seconds under the water and that's it. In order for hand hygiene with soap and water to be effective, it has to be for 30 seconds. And we have to scrub the palms, the backs of the hands, and the nails, and the tips of our fingers, all the areas of our hands. And we use soap and water when you have visible soil on your hands. But in order to make our lives easier and to decrease the time that we need to perform hand hygiene, now there are alcohol-based hand rubs. They need less time to use effectively. They need only 15 seconds. So you put some on your hands and you rub and you rub and you rub for 15 seconds until it dries. They are more accessible than sinks because you have a bottle of hand rub between each room and inside a patient's room as well. So they are more accessible than sinks, because with sinks you have to travel to the nursing station at each point in time, perform soap and water hand hygiene, and then come back. With the alcohol-based hand rubs, you improve compliance because it is easier for people to do. So basically, hand hygiene is the single most important way to prevent transmission of infectious agents. It's a fundamental aspect of infection control. However, unfortunately, compliance among healthcare workers remains poor despite wide acknowledgement of its importance. So if I quiz you or I quiz anybody about hand hygiene, they will tell me, yes, of course it's important. But when you go and you see their practices, people are not always compliant. At AUBMC, we are always targeting 90% compliance with hand hygiene. Whenever we drop below 90% hand hygiene compliance, we take drastic measures. We hope to be able to target 100%, but we have to be realistic. 90% target is very important because compliance less than that is associated with poor patient outcome. And it is our responsibility to maintain good patient outcome and to be protectors for the patients rather than sources of infection. And with